Hello students, I am Dr. Sachin Budhiraja. I am a practicing consultant and a faculty in medicine. I am also the editor of this book on ENT, that is ENT for entrance exams. This book is highly popular and the best-selling book on ENT. This book is absolutely necessary while clearing the PG entrance exams. Nowadays it is going to become next level 1, as well as this is of utmost importance while appearing for our university exams in our third year of MBBS and next level 2 also, which is going to come in the coming years after the internship. uh, in these With this channel, I am going to start a series of discussions on medicine, and today's topic which I have selected for you is regarding the disorders of the kidney. Well, with this next level of, next pattern of examinations, the clinics, have now officially also become of utmost importance. And therefore, we need to have a clinical approach right from the beginning towards any topic, right? So, how do we deal with the kidney disorders in our routine day-to-day clinical practice, in our medicine OPDs, in our emergencies, and in medicine wards? So, before the basic approach, first of all, we need to be aware of what all disorders or diseases in the kidney we are going to confront with, right, in the clinical practice. Now, as far as the kidney is concerned, uh, anatomically, broadly, we can classify the various structures inside the human kidney into four broad categories. For example, if I ask you what is the structural and functional unit of the human kidneys, yeah, you are right. A nephron is the basic structural and the functional unit in the human kidneys. And you all know that a nephron is made up of two parts, the glomerulus and the tubule, right? So here I am going to draw a very simple picture of the nephron, right? So we have the glomerulus capillaries here, right? And this part of the nephron is called as the tubule. Now, just a little observation here I want you to, the glomerulus is not only the capillary tuft. The glomerulus includes this initial part of the tubule, you call it Bowman's capsule, right? So just remember that when we say glomerulus, so this means the capillary tuft across which the filtration is occurring and this initial portion of the tubule. And remaining part of the tubule is what is the tubular aspect. And then besides, the glomerulus and the tubule, that is this nephron, what else in the human kidney? We have the vasculature, right? You all know that renal artery, enters the kidney at its hilum, and then once it enters into the kidney, it gives off the segmental branches and then further branches, and ultimately the afferent arteriole, it gives rise to, which supplies the glomerular capillary tuft. Now, uniqueness in the kidney is that normally we all know that the capillaries, they drain into venules, but in the kidney, we have a dual capillary structures. So the glomerular capillary tuft, ends into another arteriole, and that is basically this efferent arteriole. Now this efferent arteriole, gives rise to another set of capillaries around the tubules, and this is labeled as peritubular capillaries. And then ultimately peritubular capillaries, they drain into venules and then smaller veins, and ultimately the blood comes out from the kidney at its hilum through the renal vein. So besides glomerulus, besides tubules, we have the vasculature inside the kidney. And then lastly, this glomerulus, these tubules, this vasculature, has been put into a ground tissue, and that ground tissue is called as the renal interstitium, the white background of this slide. So this vasculature, the glomerulus, the tubule has been put into a ground tissue. You call it interstitium. Right, so as per the basic anatomy, these are the four structures down there in the human kidneys. So accordingly, we have four types of kidney presentations in our day-to-day practice: the glomerular diseases, the tubular diseases, the interstitial diseases, and the vascular diseases. In the glomerular pathologies, again we have two types of presentations. One is the nephritic kind of presentation, and another is the nephrotic kind of presentation, right? So we have nephrotic kind of presentations, we have tubular kind of presentation, we have interstitial kind of presentation. Often the tubules and interstitium, they are frequently involved, so we call them tubulo-interstitial pathologies. And then the vasculature kind of presentation. Okay, besides these, we come across a patient in the medicine emergency, who has gone into renal failure, right? So this is another kind of presentation among the kidney disorders, that is renal failure. Now, this patient has come to us, with some complication arising out of the renal failure. And when you take the history, and suppose if the patient says that, few days back he was absolutely fine, and within few days, due to this or the other reason, we'll discuss ARF in details. So this patient has gone into renal failure, and you label this condition as acute renal failure. As I said, acute means that an illness which has happened over few days. Right? So this patient has gone into acute renal failure. So you need to, this patient is a really sick patient, and you need to admit this patient. He needs at times ICU care also, and you need to tell the relatives that, see, presently the kidneys are not working, and we need to put the patient therefore on dialysis. But though there is mortality associated, that the patient's condition is really bad, but often this condition is reversible, and the patient will ultimately come out of its illness. Now at this point, the relatives are going to ask you a very important question, that, doctor, we have two kidneys, so when you are saying that my patient has gone into renal failure, so what do I understand? I mean, is he into one kidney failure, or both the kidneys have gone into failure? So you need to tell that, see, whenever we speak about renal failure, we mean that both the kidneys are not working, right? Because had it been one kidney failed, then the patient wouldn't have developed any symptoms, less to talk about any complication, because with one single functioning kidney, a person can live his life absolutely normal. Normally there is no manifestations at all. This single congenital kidney is not something rare. It is not something rare. Every 1000 or say 1500 births, one person tends to have a single functioning congenital kidney. Right? So you need to tell them that when we speak about renal failure, we mean that both the kidneys are not working. But then it is a general thing that any acute condition, though severity is there, mortality is there, but it tends to be reversible. And this is omnipotent with the other clinical subjects also, you will find. For example, this coronavirus scare is going on presently in the world, but then ultimately the people are going to the patients are going to recover. The mortality is there with coronavirus, this COVID-19, the mortality is there around 2 to 3%, but then majority of the patients are ultimately going to recover without any permanent organ damage. So this is a general rule with any acute illness, and so with acute renal failure also, that the condition is reversible, right? Now again, one more presentation in the disorders of the kidney is this chronic kidney disease, right? So as I enumerated previously, that here we have glomerular presentations, and in the glomerular presentations we have nephrotic kind of diseases, we have tubular presentation, we have interstitial presentation, often existing as tubular interstitial disease kind of presentation, and we have vascular pathologies. And at times these pathologies, they have a remitting, relapsing kind of nature, they are chronic in nature. And therefore, the patient goes into a chronic kind of insult into the kidney bed, and we define it as chronic kidney disease. Like I was mentioning, acute means few days. Chronic means generally months to years. So by definition, more than 3 months, if a patient is into ongoing kind of renal insult, so we describe it as chronic kidney disease. Now, chronic kidney disease is typically a progressive condition, right? It is a progressive condition, and what happens here that with time the GFR keeps going down. So if you see the natural history of a CKD patient, you are going to find this kind of graph. Say on x-axis, if this is the GFR, on y-axis if this is the GFR, on an x-axis if this is the time in years, then with time the GFR is going to progressively go down, right? So this is the natural behavior of a CKD disease process. So that after years, ultimately the GFR goes below to a value which you need to remember, because they ask you this in exams, that once the GFR goes down to below 15 ml per minute, then we say that the patient has gone into end stage renal disease. So end stage renal disease means, the term itself is explanatory, that the kidneys are now not functioning, right? So again, the same thing you need to explain to the relatives, that both the kidneys are not functioning, right? And we are labeling this case as end stage renal disease. So at times the patient raises this query that, doctor, you are saying that the kidneys are not working, but we are observing that our patient do pass urine. Yeah, the urine quantity is less, but he does passes some amount of urine in a day, and you are saying that the kidneys are not working. So you need to explain that, see, the total GFR of the human kidneys is 120 ml per minute, right? So please clear your concepts that when we say 120 ml per minute kind of GFR, so we mean to say that it is the total GFR, right? So 60 ml from right kidney and 60 ml from left kidney. So it is the total GFR to be 120 ml, and once the total GFR goes below 15 ml from both the kidneys, then we say that the patient has landed up into ESRD, and percentage wise if you calculate, then 120 ml is the total, it has gone down to below 15 ml. So roughly around 90% decline in the glomerular filtration rate, the patient has landed up into end stage renal disease, and it's a permanent irreversible decline in glomerular filtration rate. So you will say that 10% of the kidneys are still functioning, and that is why your patient is having a low urine output, and medically we define this low urinary output as oliguria, and you should know the definition of oliguria, that is the urine output which is less than 500 ml over 24 hours, right? So normal urinary output, it depends upon the water intake, it depends upon the surrounding temperature, but roughly normal urinary output is around 1.5 to 2 liters per day. So if it is going down to below 500 ml per minute, you say that it is oliguria. So your patient is oliguric because 10% of the kidney is still functioning, but this function, remaining 10% is not sufficient to carry on the complete excretory function of the human body, and therefore the patient can land up in some or the other complication very soon. So what is the treatment with end stage renal disease? Yeah, temporarily we can maintain the patient on dialysis, but practically speaking, if an organ has failed, we have no option but to replace the organ. So kidney transplantation is the best modality, to treat these end stage renal disease patients. Kidney transplantation offers the best quality of life as well as the quantity, the survival. So both the survival as well as the quality of life is best with kidney transplantation. So this is the treatment. And again, as I said, one single kidney is capable of adequate excretory function, is capable of carrying out the complete excretory functions in the human body. So the relatives need to, just arrange for one single functioning kidney. That's all. Right? So these are the various presentations of the kidney disorders which we come across in our routine clinical practice. Now, out of these various presentations which we have found, that is the individual nephritic and nephrotic diseases, the tubulointerstitial diseases, the vascular diseases, acute renal failure, chronic kidney disease, ultimately, ending into end-stage renal disease. So of all these presentations, the commonest presentation, or I would say the largest chunk of patients suffering from kidney disorders, they belong to this category, that is chronic kidney disease. So this disease represents the largest number of kidney patients in our routine day-to-day clinical practice. And why CKD is the commonest, presentation? Because the underlying causes, if you'll get to know. So you'll get this, why CKD is the most common presentation. Now the most common cause of CKD worldwide is diabetes. So this is the leading cause of CKD worldwide. And presently, we have a lot of type of diabetes, but you all know the commonest is, right, type 2 diabetes. Right? In fact, type 2 diabetes constitutes, more than 90% of all the cases of diabetes. And therefore, type 2 diabetes is the most common underlying cause of CKD worldwide. And like this coronavirus epidemic, we are also into an epidemic of type 2 diabetes. And the reasons are two. Type 2 diabetes, so there are two underlying reasons. So what are these two underlying reasons? So if I ask you, of the two major types of diabetes you know of, that is type 1 and type 2, which type of diabetes is having a more genetic predisposition? No, it is not type 1. It is type 2 diabetes which has a strong genetic predisposition. So high likelihood that, the disease will come from parents to offsprings, and it is a polygenic kind of inheritance pattern here, right? And the second underlying cause for type 2 diabetes are again, two. One is this obesity, thanks to McDonald's and KFCs and these delivery systems of Swiggy and Zomato and what all, and the physical inactivity. So obesity and physical inactivity, these are the two reasons behind the occurrence of type 2 diabetes. So I will highly appreciate those students who are watching me while doing a brisk walk in the nearby park, right? So type 2 diabetes is the leading cause of CKD worldwide, and where is the impact in the kidney? As I said, there are four structures down there: the glomerulus, the tubules, the interstitium, and the vasculature. So where is the impact of diabetes inside the kidney? Well, diabetes is something generalized illness. The metabolic abnormality here is hyperglycemia, And besides kidney, a lot of other organs are also involved, and in the kidney also, all these structures are involved, but most commonly the impact is on the glomerulus, right? This is something important, and the condition is described as here as diabetic nephropathy. So it is largely a glomerular involvement. So I'll speak about diabetic nephropathy in my second video. Then the second most common cause of CKD worldwide is another common, day-to-day condition, and that is hypertension. So this is the second leading cause of CKD worldwide. So these two are such common conditions, as I said, therefore CKD is the commonest presentation among the various kidney disorders. Hypertension, you all know, will be having an impact on the vasculature, and it is typically the resistance vessels, which go into damage. You must have heard of this term in your pathology, that is hyaline arteriolosclerosis. Right? So this is what happens with hypertension: vascular damage and ultimately kidney damage. Then third leading cause of CKD worldwide is primary glomerular pathologies. Like as I said, diabetes also involves largely the glomerulus, but this glomerular involvement in the background of this multisystem disorder, diabetes, is a secondary involvement. So when I say primary glomerular diseases, I mean to say primary means that only the kidney is getting involved, right? So primary glomerular diseases means the primary nephritic as well as nephrotic diseases. So these are the third leading cause of CKD worldwide. Now in certain textbooks of medicine, you will find that the term which is written is CGN, chronic glomerulonephritis, as the third leading cause of CKD. Now this term is a little misnomer because reading this term chronic glomerulonephritis, it indicates as if it is the nephritic illnesses which go into which continue and cause CKD. No, it is the nephrotic illnesses also, right? So primary chronic glomerular diseases is the right term to describe the third leading cause of CKD. Then what is the fourth leading cause of CKD worldwide? Now this is an inherited condition, right? So an inherited condition is the fourth leading cause of CKD. So quite common, 1 in 800 people, they tend to develop this disease, and this disease is inherited in an autosomal dominant fashion. I'll give you one more clue. This disease typically manifests in the adults, right? Though it is an inherited condition. So I think you got it now. I'm talking about autosomal dominant polycystic kidney disease. As I said, this is a disease of the adults, inherited as autosomal dominant fashion, and this is a very important question. So another important question in the Viva OC here, that where is this cysts forming? So as I said, where is the cyst forming? Is it in the glomerulus? Is it in the vasculature? Or is it in the tubules? So again, nothing to mug up here. Cysts, you all know, are something which are lined by epithelium. So answer is tubules, right? So the cysts, so the tubules which are lined by epithelium, obviously. So in ADPCKD, the cyst formation occurs inside the nephronic tubules. Then what is left? The fifth cause of chronic kidney disease. This is another very important cause. So what we are left with, the first condition we talked about was diabetes, involving every structure down there, the glomerulus majorly, most commonly. Then we talked about hypertension involving the vasculature. We talked about primary glomerular pathologies, again glomerulus, and then this ADPCKD cyst formation in the nephronic tubules. So we are left with an individual involvement of the interstitium, renal interstitium, and this condition is described as chronic interstitial nephritis. Chronic interstitial nephritis. Now, interesting thing with this condition is that how the interstitium is getting involved. Well, this disease happens due to the problems in the urological tracts. due to the problems in the urological tracts. So you all know that we have the ureters, we have the bladder then, and then subsequently we have the urethra. So these ureters, they have this initial portion that is, renal pelvis area, so that is also part of the urological tracts, and then here we have the kidneys, right? So if I ask you, what is the most common urological disease you are aware of? No, 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 it is not stones. Huh? The most common urological disease in our clinical practice is, if I give you a clue, I can develop that disease. Those students who are males, they can develop that disease later on. Yeah, you got it now. This is benign prostatic hyperplasia. This is the commonest urological disease in our day-to-day practice, and you all know that here, because of the physiological male hormone related enlargement of this prostate gland, which is there in the males only, obviously. So here we have the obstruction of the bladder neck region, and as a result there is back pressure, right? And with this back pressure, the interstitium is going to get involved. I'll explain in a little later. Then, besides benign prostatic hyperplasia, the commonest obstructive uropathy, we have other obstructions also, as you said, in the form of stone, stricture, and other causes. Then another urological disease you must have heard of, that is called as VUR, vesiculourethral reflux. So, which is again a congenital issue, and again you can easily remember, like BPH is exclusively seen in males because prostate is there in the males only. VUR, congenital anomaly, is also seen predominantly in the male children. So with these two conditions, what happens? There is a obstruction here, and there's a reflux here. So as a result, the urine is held back into the higher tracts, right? Now, suppose that the urine is being held back in the bladder, or say in the ureter, or say in the pelvis, then there is no issue, because urine. Why there is issue? Because urine contains waste products. When we say waste products, we talk about urea and creatinine, and this is something I would say oversimplification. These two waste products we measure in our routine laboratories in evaluating these patients of kidney disorders. But as I said, this is an oversimplification. We have hundreds of waste products being excreted in the kidneys, and urea and creatinine are just two of them. And besides these waste products, we have metabolic acids also being eliminated. So these waste products and these metabolic acids also, are there in the urine, which is being held back now due to these illnesses. Now, nothing happens to the bladder or the ureter or the pelvis, because these structures are lined by the transitional epithelium, and you all know that this transitional epithelium is lined by it is a epithelium which has 4 or 5 epithelial layers, right? It is quite thick. But imagine if this urine is going to held back, and now this urine is going to be collected and allowed to stay in the delicate tubules. I'll show you this slide. Yeah. So these are the various parts of the nephronic tubule. This is the proximal columnatory tubule, then loops of Henle, then distal columnatory tubule, and then it is ending into this major duct. You call it collecting tubule or collecting duct, and most of the collecting ducts are now joining in the end, and you can make out that here we have the scribriform area where these tubules are ultimately opening. And if I show you in the gross anatomy, then this is the gross anatomy. This is the coronal section, and these are the renal medullary pyramids. So these renal medullary pyramids are ending in this area, which is the scribriform area, where these kidney the nephronic collecting ducts are opening, right? So ultimately, the urine is drained at these tips of these are called as speculary regions. So at these tips, the urine goes into minor chelicus, and then major chelicus, into the finally into the renal pelvis area, and then down the ureter. So if the urine is held back, then through this pelvis and major chelicus and minor chelicus into this scribriform area, into the speculary area, and then ultimately into the and then tubule is something very delicate structure lined by a single epithelium. So these waste products and these metabolic acids are now then going to infiltrate into the interstitium and thereby leading to inflammation of the interstitium, right? So this last condition causing CKD arises due to the urological diseases, and BPH, mind you, is the commonest urological illness in our day-to-day practice. Now this is a time to introduce one last kidney presentation in the medicine, and you must have heard of this presentation, that is pyelonephritis. So what is pyelonephritis? It's two terms. Pyelo means pyelitis, pelvis, renal pelvis, inflammation of the renal pelvis, and nephritis means inflammation of the renal interstitium due to infection, right? And how this infection reaches the pelvis and renal interstitium? Again, these are ascending infections. These are our own fecal flora, right? E. coli is the commonest bacteria, you all know, and it is because of this bacteria ascending infections and ultimately involvement of the renal pelvis and interstitium. So pyelonephritis, and typically this pyelonephritis occurs because of the urological tract diseases, as I said, commonest being BPH and other obstructions, stone stricture, etc., and then VUR also, right? So with the patient presenting with pyelonephritis, high-grade fever, these patients, they tend to have, these patients, because of the inflammation into the renal interstitium, and as a result the swelling, so the kidney is surrounded by a very tough capsule, so there is stretching of the renal capsule, and as a result these patients, they tend to have along with fever, very severe pain in the loin region, and you can elicit the tenderness also at the same area, that is the area of the you describe it as the renal angle area in the back, right? And at times, because of the organ involvement, these patients, they are going to sepsis also. So similarly, we can have a chronic pyelonephritis also, where we have a low-grade kind of infection going on, and right. So these are the various presentations of kidney which we come across in our day-to-day practice, right? So in my next video, I'll take this topic of diabetic nephropathy. So I hope you are getting benefited through this video channel. So do subscribe. Knowledge is for sure. So do tell your friends to join this channel. And lastly, go through any textbook of medicine, whether Davidson or CMDT or Harrison. These are three standard textbook of medicine we follow. And my last advice will be that do go through this ENT for entrance exams, which is a non-stop which is a one-stop book. I mean, there will be a non-stop reading, I hope, because the book is has been written in a very simple language by Dr. Manisha Budhiraja, and this is her only authentic work. We have no other work, whether online, offline, no question bank. This is the only authentic work of ours, so do go through it. You'll be immensely benefited for sure. Thank you.